Hello everyone. I would like to welcome you today for another webinar organized by Saudi Society for Blood Disorder in collaboration or support, unrestricted support from Novo Nordisk. So today webinar will be about hemophilia. We are glad to have two distinguished speakers. Dr. Fawaz Al-Qasim and Dr. Manuel from Canada. So the webinar is for 1.5 hours. Both speakers will be talking for 30 minutes for a total 1 hour. I would like to kindly ask the attendees to type their questions in the Q&A, and we'll try to address them as we go. I would like to announce also we have now around 500 plus attendees with us now. I would like to welcome them all. So the first talk will be by Dr. Fawaz Al-Qasim. Dr. Fawaz Al-Qasim is a very well-known pediatric hematologist oncologist from Saudi Arabia. He's a senior consultant in King Saud Medical City. Also, he plays several roles in different national organizations. So Dr. Fawaz will be talking about joint health and functional ability in children with hemophilia. Dr. Fawaz, the mic is yours.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Firas. It's a pleasure to be here with you today. I'm going to talk about joint health and functional ability in children with hemophilia. As you all know, hemophilia is quite common. It's the second most common bleeding disorder after von Willebrand disease. And although we don't have a local data, internationally, the incidence of hemophilia is about 1 in 10,000. And I think our local figure is not far from this. It's caused by factor VIII deficiency, and it's resulted from mutation in factor VIII gene located in the X chromosome. So it's an X-linked recessive. More than 99% of reported cases is in male. About 2/3 of the cases is having a positive family history, and 1/3 happen as a new mutation. Hemophilia classified based on severity to mild, moderate, and severe. The mild cases, which about 1/4 of the cases have a factor VIII level between 5 and 40, these patients is usually they don't bleed spontaneously, they bleed only after significant trauma or surgery. The moderate cases have a factor VIII level between 1 and 5. Occasionally, they can have spontaneous bleeding. However, usually they present again after minor trauma or surgery. The majority of cases, the severe one, those who have a factor VIII level less than 1, usually they bleed spontaneously, mainly in their joint or muscle. And these are the group of patients who need special care. A typical lab investigation in hemophilic patient will show a normal CBC, including platelet morphology and platelet count. BT usually normal, however, the BTT will be prolonged. The diagnosis will be confirmed by factor VIII assay, and to know the exact gene mutation, you have to do the factor VIII gene sequencing. The hallmark of hemophilia is hemarthrosis. And usually it's present with joint swelling, limitation of movement, and pain, and recurrent hemarthrosis will lead to joint destruction. Hemarthrosis usually occur in the synovial joints, and the most affected joint by far is the knee, followed by ankle and elbow. Less commonly affected joint, including shoulder, hip, and wrist. After the joint, it's the muscle, which again commonly affected, which include forearm flexor, quadriceps, calf muscle, hamstring, iliopsoas, and biceps muscle. Hemarthrosis will lead to joint destruction either by direct damage or indirect damage, and the direct damage either through pain that will cause limitation of movement, which lead to muscle atrophy and arthropathy, or by altering the cartilage metabolism that will inhibit proteoglycan synthesis, leading to cartilage destruction and arthropathy again. Indirect damage will happen by bone remodeling that will cause osteoporosis and arthropathy, or by synovitis or vascular proliferation, both of them will lead to synovial hypertrophy that will release catabolic enzyme, which lead to cartilage destruction and again arthropathy. The joint destruction by hemarthrosis pass through different stages. Even a single bleeding episode can provoke synovitis. However, recurrent bleeding will lead to swelling of the joint and ongoing synovitis. Growth of synovium will lead to inflammation and new vascular formation, which is usually fragile and stable, that will break down easily, leading to further bleeding episode with further cartilage destruction. Destruction of the cartilage will lead to long-lasting joint damage that result in arthritis and stiffness of the joint. In the latest stage of joint destruction, there will be complete loss of cartilage and the bone may become deformed, changing the shape of the joint completely. And at this stage, joint replacement will become mandatory. These are some of the signs of disease progression, which include frequent bleeding, persistent pain, swelling, reduced range of motion, crepitus during movement, reduced muscle power, and abnormal gait and abnormal balance. What are the consequences of joint damage? Joint damage will lead to chronic and consistent pain. It will impair the ability to perform daily activity and normal life. It will require some support for normal walking, and it will require mobility aids. It will impair participation in life events like sport and work, and it will definitely affect the quality of life. Assessment of joint on a regular basis is essential in patients of hemophilia. It will be important to detect deterioration in joint condition and to detect failure of current treatment regimen and to determine whether an alternative management plan is required. Joint assessment can be done by either physical assessment or by images, and commonly you need to use both modality to do a joint assessment. The commonly used physical assessment, including the World Federation of Hemophilia Orthopedic Scale, Hemophilia Joint Health Score, Colorado Physical Examination. Whereas images including simple X-ray by Arnold scale or Peterson score, or by using MRI or ultrasound. The musculoskeletal examination is used to assess the function impact of treatment. However, it's not sensitive and it's very difficult to detect any changes, especially in early stages of the disease. There is available and validating functional assessment, which include either assessing the joint or more generally assessing the quality of life. The joint evaluation assessment, including Hemophilia Joint Health Score or the Colorado Hemophilia Pediatric Joint Physical Examination. Whereas the quality of life assessment, including the Hemophilia Quality of Life or Childhood Health Assessment Questionnaire. What do physical assessment measure in patients with hemophilia? The World Federation of Hemophilia Orthopedic Scale, as well as the Hemophilia Joint Health Score, both assess and measure the joint health in terms of body structure and function. They are used to assess commonly affected joint, and they are used when there is a need for orthopedic intervention. It also measures the outcome of physiotherapy intervention. When you do physical assessment, you should be very careful because physical assessment can aggravate symptoms or even lead to hemarthrosis. And many occasions you might need to give replacement therapy by giving factor VIII before you do the physical assessment. These slides show the main differences between World Federation of Hemophilia Orthopedic Scale and the Hemophilia Joint Health Score. Regarding the population, the World Federation of Hemophilia scale use in both pediatric and adult and use mainly in established arthropathy, whereas the Hemophilia Joint Health Score use usually in children between the age of 4 and 18 years and tend to be used more in mild to moderate joint impairments. Regarding the timing of doing the study, the WFH scale usually takes 30 to 45 minutes without the computing time, whereas the Hemophilia Joint Health Score takes 45 to 60 minutes. The scoring in WFH scale, including specific joint score as well as total joint score, whereas Hemophilia Joint Health Score, including specific joint score, total joints score, as well as gait score. Other differences, the WFH scoring is less sensitive than Hemophilia Joint Health Score, but it can distinguish between mild, moderate, and severe cases, and it's better used in adult and older children. Whereas Hemophilia Joint Health Score is sensitive to changes even in mild arthropathy, but it's not yet adequately studied in adult and not yet adequately studied in very severe joint damage. This sheet is an example of Hemophilia Joint Health Score scoring system. It's including the data about the patient, including the subject ID, the name of physiotherapist who did the assessment, assessment number, date, and time of the assessment. And it's evaluate the commonly 6 commonly affected joints, namely right and left knee, right and left elbow, and right and left ankle. And the element of assessment, including swelling, duration of swelling, presence of muscle atrophy, presence of crepitus, flexion and extension loss, joint pain, joint strength. Then you have a total score for each joint, and the sum of all joint score in addition to the global gait score will give you the total Hemophilia Joint Health scoring data. Like any other chronic diseases, hemophilia quality of life is very important in hemophilia patients. And quality of life can be assessed by number of lost days or at school or work for caregiver, by hemophilia activity list like self-assessment questionnaire and functional abilities, or categorical scale like estimated precise aspect of treatment. Another method of assessing joint status beside physical assessment is radiological. And the conventional method of assessing by radiology is the plain X-ray. Plain X-ray being used for so long time and assessing joint status. However, it has its own limitation. It's better than physical assessment, but it's unfortunately doesn't give a detailed data, especially in early stage of joint damage. And also it doesn't study the soft tissue. So joint disease is often underestimated by using simple X-ray. This is an example of World Federation of Hemophilia radiological assessment by Peterson scoring. It's an additive system. Each abnormality is recorded and get grade from 0 to 1 to 2, as 0 normal, 1 mild damage, and 2 is severe damage. All abnormality is recorded in this scale. However, this scale doesn't include soft tissue monitoring. The highest score is 13 when there is complete joint damage, and 0 when the joint is completely normal. And this is the element of assessment, including osteoporosis, presence of a large epiphysis, irregularity of subcondylar surface, narrowing of joint space, subcondylar cyst formation, erosion of joint, differences between joint surfaces, and joint deformity. So for a normal joint, the score will be 0, and for a totally destroyed joint, the score will be 13. And of course, the range is vary between these two. And here is an example of knee joint X-ray with scale. As you can see, in the left side, this is a normal, completely normal joint with a score of 0. In the right-hand side, these patients have osteoporosis. There is narrowing of joint space. There is overgrowth of epiphysis, and there is irregularity of surface. So the score on this patient is 8 with moderate joint damage. Another modality of assessing joint is by ultrasound, which is a better way of assessing joint compared to X-ray. It has the advantage of assessing muscle, tendon, joint, blood vessel, as well as internal organ. It also gives you the chance to measure the size, shape, and structure of potential pathological lesion. In your right-hand side, you can see an example of knee assessment, and there is significant effusion. I don't know if you can see my arrow. There is a significant effusion here, and as pointed by the arrow, there is sinusitis as well. The advantage of ultrasound, it's a high quality images. In fact, it's compared to the gold standard of assessment, which is MRI. It's fast, it's inexpensive, and it's dynamic. So in even a single episode of bleeding, you can do a daily ultrasound assessment to assess the progress of the hem arthrosis. And it doesn't require sedation in children, which is a big advantage. It has a therapeutic potential. So you can do ultrasound guided injection, puncture, or even biopsy, and it can give an objective parameter like the size of lesion and sinusitis. The main problem of ultrasound, it's operator dependent, unfortunately. So it depends on the experience and the background of the radiologists who do the ultrasound, and the same joint can be given 2 different reports by 2 different people. And also it is, there will be variability depends in the instrument itself, the ultrasound, how sensitive is the ultrasound. And of course, it requires special training. Not everybody can do a detailed joint assessment. And it doesn't provide a good view of a whole joint by a single study, and bone is not very well visualized by ultrasound. MRI is the gold standard of assessing joint damage and hemophilia, and now many studies that used to assess the efficacy of prophylaxis or new medication use MRIs as their references. A single MRI study can give you 100 or even tens or hundreds of images, and MRI doesn't use radiation, so it is safe, and it's widely used in diagnosis with visualizing even a fine detail of joint damage. We can see here 3 examples of joints study by MRI. In the A study to your left hand, you can see there is a moderate synovial proliferation indicated by arrow, indicating a significant joint damage. In the B study in the middle, you can see here there is a significant hemosiderin deposit indicating recurrent hem arthrosis. And in a C study to your right-hand side, there is significant joint effusion in study C. What are the advantage and disadvantage of MRI? As I mentioned earlier, the main advantage, it is the gold standard, and it provides the best images. It allows imaging of the whole joint, including the bone. It detects even preclinical changes, and it is validated for both pediatric and adult. The limitation is accessibility. Not everybody have MRI, and the complexity of a study also, it's need an expert radiologist to have a good report, and it's quite expensive to compare to the other modality. Children, unfortunately, may require sedation because a full study might take some time, so you might need to sedate children to do the study. MRI assessment has been used as a key recent prophylaxis study, and MRI scoring protocol has been validated for both pediatric and adult. Treatment of hemophilic patient is very costly, and there is direct and indirect cost for the treatment. The main direct cost going to the factor replacement, other direct costs including cost for the physician, the clinician, the other healthcare worker like nurses, physiotherapists, social worker, and others, hospitalization costs, emergency visit costs, outpatient procedure, lab tests, other hemophilia-related medication, mainly the painkiller, paid caregiver costs, medical devices, especially in advanced cases, and non-medical costs. And direct costs, including lost working and school days, lost working time by parent and other caregiver, and caregiver services, and impact of quality of life, which sometimes being very significant. Physiotherapy is very essential in patients with hemophilia. Exercise programs are designed and implemented for two main purposes: to manage the recovery after bleeding episode, as well as a tool to help to prevent further bleeding episodes. Physiotherapy is also important to support recovery from surgical procedure. The aim of physiotherapy is to maintain healthy joint and avoid deformity, to reduce pain, increase patient function by maintaining full range of movement, increase muscle strength and minimize potential for bleeding, improve balance, which help to avoid injury, and help the patient to remain fit, active, and maintain healthy weight. Thank you very much for your listening. Thank you. Dr. Firas?
Hello.
Yes.
Assalamu alaikum.
Alaikum assalam.
Thank you, Dr. Fawaz, for your
Hi,
interesting.
Dr. Hassan.
Sorry for being late.
We were waiting for you for some time.
No, I started a few minutes later, but
Okay.
unfortunately, we have a time difference, and I'm here outside the kingdom, and there is time difference for the meeting. Sorry for that. I'm trying to be on time, but I did all my best. Anyhow, you have been already introduced by somebody else, but I've been listening to your interested talk about the health of the joint status, and that was very interesting. But I found it's it's the main backbone for the management of hemophilia, is to keep your joint healthy as much as possible.
Totally agree. Yeah.
Now we are moving to the second speaker, right? Hello.
Hello, I'm here.
Hi, Dr. Karkau. How are you?
I'm well, thank you.
We have the honor to have you in this meeting, and I think we don't know, like we know each other from a long time since I was in Canada. Professor Karkau is well known in the field of hemophilia, bleeding disorder, blood disorder, not just bleeding, inhibitors in hemophilia. I think now he become like well known also as a researcher with many interest in hematological disorder. And today he will give us a very good talk about the long-acting factor 8, like Esperant. And as he mentioned, put his slide, simple way to achieve low annual bleeding rate. And this is the main purpose of any treatment for hemophilia, to lower the annual bleeding rate. Welcome, Dr. Karkau, and please start.
Well, thank you. Thank you very much for this kind introduction. I want to thank Novo Nordisk for inviting me to participate in this and to give this talk. I also want to thank Fawaz for an excellent talk that he gave. and it really set the stage for what I'm going to talk about. I was asked to talk about Esperant, which in Saudi Arabia will be, I think, a new product that will hopefully become available sometime this year or within the next year. And as Fawaz showed you, hemophilia is a very bad condition. And it's a very bad condition if you don't prevent bleeds. So the prevention of bleeds, which we call prophylaxis, is so important. Because if you don't prevent the bleeds, the joints will be damaged. And when the joints are damaged, the quality of life of a person with hemophilia will be very bad. So it is very important to prevent bleeds. And to do so, we've relied on prophylaxis. And to do prophylaxis, up until recently, the only way is with factor. And so how long factor lasts is very important, because if it doesn't last very long, people with hemophilia will need to get a lot of needles in order to maintain a certain level of factor in them. And so bringing extended half-life products, I believe, is very important, because it does make life a little bit easier for all these patients with hemophilia. So with that background, I want to talk about Esperant. And as you heard, the title of this presentation is A Simple Way to Achieve a Low ABR. Here are my conflicts of interest. I've worked with many different companies over the years, including Novo Nordisk. I've received research support from various and have been asked to speak at various industry-sponsored things and advisory boards as well. This is the agenda for what I'm going to talk about. I'm going to talk about Esperant, the molecule itself, its clinical development, some of my personal experience with it, and then hopefully there will be questions and hopefully there will be answers to those questions. So Esperant, the molecule. So Esperant is also known as Nhgp, and it's also known as teroctocog alpha pegol. Obviously the pegol stands for pegylation. So it's a teroctocog alpha, which is N8, that's pegylated, and hence it's Nhgp. So this was formerly known as N8GP, and now it's really known as Esperant. It comes in vials between 500 units to 3,000 units, and each vial is reconstituted with 4.3 mils of normal saline. So Esperant is N8GP, also known as teroctocog alpha, that's been linked or has attached to it a polyethylene glycol molecule, a 40 kilodalton polyethylene glycol molecule. The teroctocog alpha itself, or the Novo 8, is a third generation B-domain truncated recombinant factor 8 that's produced without any animal or human-derived materials in Chinese hamster ovarian cells or CHO cells. And shown on the next couple of slides is how Nhgp becomes activated. So what I'm showing you here is that the polyethylene glycol is attached in a site-specific fashion to the truncated B domain. And so when a bleed occurs, as we all know, a little bit of thrombin is generated. And when that thrombin is generated, that thrombin is going to cut and activate this molecule. And in doing so, what will happen is that the PEG, along with that B domain, the truncated B domain, is going to be thrown out of this, and you're going to be left with the activated factor 8 that then participates in the coagulation cascade, amplifying the production of thrombin. Esperant, and this is especially important in a place like Saudi Arabia, is a little bit different from other factor 8s or even extended factor 8s because it has a high tolerance for heat. So like most factor 8s, it should be refrigerated and kept in the refrigerator. And if you do, it's good for up to 30 months. That's 2.5 years that a patient can have this sitting in a refrigerator. But it's also good up to 40 degrees Celsius for up to 3 months. So you can actually have it outside of the refrigerator with temperatures up to 40 degrees for up to 3 months. Now, I wouldn't advise that you should do that, but you can do that. And so that's actually very important in very hot countries like your country. Now, a little bit about the clinical development of Espera. So Espera was developed through what's called the Pathfinder program, which is a Novo Nordisk program. The program consisted of 8 studies or clinical trials named Pathfinder 1 all the way to Pathfinder 8. Most of these trials are now completed. Some are still ongoing. Importantly, Espera got FDA and EMA approval in 2019. So this is an FDA and EMA approved product. It's also Health Canada approved product, and it's approved in many other parts of the world. On the Pathfinder clinical trial program, there were a total of 270 patients that were placed on the program and were treated with this product, Nhgp or Espera. Some patients, including my own, have been on the product for over 8 years. The countries that participated in the clinical program, the trial program, are shown here in the blue, and this includes Canada. Now, this is actually one of the most important slides, I think, because it really has to do with the benefit of extended half-life products over standard half-life products. So Espera is an extended half-life factor 8. And on the original Pathfinder 1 trial, which was published in 2013, so this is 8 years ago, what you see here is that in adults that participated in this clinical trial, they underwent a pharmacokinetic evaluation with the previous product that they were on, so the previous factor 8, and these adults on average showed a half-life of 12 hours. With Nhgp, these adults on average showed a half-life of 19 hours. So 12 versus 19 hours is a 1.6-fold prolongation. What this means actually is that you can reduce the number of needles that patients get on average at least by 1 needle every week, which is 52 needles in a year. And if you start looking at over a lifetime, that is potentially not only hundreds, but actually thousands of needles that the patient would need less by moving from a standard half-life to an extended half-life product. And I was part of this smaller group that looked at all patients for which pharmacokinetic data was available with Espera. And what was found is that all patients increase their half-life when they move from their previous product to Espera. And the increase in adolescents and adults is about 1.6 times. And in children, it's actually even a little bit higher, of about 1.85 times. So the half-life is much longer with Espera than it is with standard half-life products. Now, Espera, like all factor 8s, its half-life, its pharmacokinetics, has a strong relationship with von Willebrand factor. And as you can see here on this slide, what I'm showing you is on the x-axis is patient's von Willebrand factor antigen level. And on the y-axis is their half-life with Espera. And as you can see, the higher patients' von Willebrand factor levels, the higher their half-life with Espera. And this is for both adults as well as adolescents, which are in the little blue. And there's a strong relationship between von Willebrand factor and blood type and half-life of Nhgp. So we know that in the studies that have been done using Espera, where there was a lot of detailed information, both their von Willebrand factor levels, their half-life for Espera, their blood type, there was information on a number of patients. And what you can see here is that O blood type individuals show half-lives that are much lower, of 15.6 hours on average, versus patients who are A or AB blood type who show much higher mean half-lives. But within each of these groups, there's a lot of variability. So amongst the patients who are O blood type, some patients, even with Espera, will have half-lives of only 9.8 hours, whereas others will have half-lives of up to 21.5 hours. So there's significant variability between patients and their pharmacokinetics. And although I'm not going to get into it, this is important in terms of determining the pharmacokinetics for each of your patients. So I think it is important to do pharmacokinetic analysis, and you can use the WAPS program, and we can talk about that in questions later. Now, a little bit about some data on the use of Esperant for prophylaxis and how effective Esperant is for prophylaxis. And this is very important because ultimately, all patients with severe hemophilia should be on prophylaxis, and that is part of the World Federation of Hemophilia most recent guidelines. It's not some patients should be on prophylaxis, it's all patients should be on prophylaxis. So it's very important to know, how does Nhgp do for prophylaxis? So this was looked at in the Pathfinder 2 study and its extension. The Pathfinder 2 was a phase 3 pharmacokinetic safety and efficacy trial in adolescents and adults. So those 12 years or more in age. And then the Pathfinder 5 was a similar study, but this was in children under 12 years of age. These were all in previously treated patients. So in the Pathfinder 2 trial, the adult and adolescent trial, there were 186 or 187, I'm not exactly sure why there's a difference there, but it's 186 or 187 patients were placed onto this Pathfinder 2 trial. Patients could either go on to receiving the product prophylactically, so 175 patients received Nhgp prophylactically at a regimen of 50 units per kilo every 4 days. So everybody got that regimen, which is a simple regimen. You don't have to think about it too much. Now, they did include some patients who would get the product on demand. Now, the only reason to do that is some regulatory agencies like the FDA sometimes mandate that some patients are put on it on demand just to see how that works. As I told you before, I don't believe any patient should be on demand. They should all be on prophylaxis. So the focus here is really the prophylaxis. There was a main phase to the study. All patients had to be on the main phase for at least 26 weeks, which is, of course, 6 months. But in fact, most patients were on it for much longer. And the mean amount of time that patients were on this main phase was 43 weeks. The patients that were on it on demand, the 12 patients, they just stayed on demand throughout the extension phase, which I wouldn't do now. This was in 2013 or so when this started. Of course, we would not do that now. The patients that were on prophylaxis, receiving the product every 4 days, after the main phase, some of these patients, if they agreed to be randomized, and if they had no more than 2 bleeds in an annualized fashion, so an annualized bleeding rate of no more than 2, they could then be randomized to either continue on 50 units per kilo every 4 days or be randomized to a 75 unit per kilo every 7 days. That's once a week prophylaxis. That is pretty good if you can stay on once a week prophylaxis with this product. And in total, 38 patients were then randomized to that regimen. Now, all the other patients who did not want to be randomized, they didn't want to take the chance of being on every 7 days, or if they had an annualized bleeding rate of more than 2, there were very few patients who had bleeding rates of more than 2. Those patients simply stayed on every 4 days. This was the pediatric trial, the Pathfinder 5. All children were placed on 60 units per kilo twice a week. These were all children under 12 years of age, and in total, 68 children were placed onto the Pathfinder 5 study. That included 2 children in my own center here. The main phase was 26 weeks, so 6 months, and then they just continued as part of the extension phase. And in fact, some of these children, including my own, have been on the product for more than 6 years continuously without going off of the product. Shown here are the trough levels with Nhgp in the Paradigm 2, or the adult and the adolescent trial. And what I'm showing you here is there's 2 columns. So the first column is what were the trough levels for those patients which were almost all of them, 175, that were on it every 4 days, receiving 50 units per kilo. And the mean trough level, so at the 4th day, right before they receive their next dose of factor, their trough level, the lowest factor rate level that they have at any point in time, the mean was 3%. Furthermore, in patients that were on this regimen, 50 units per kilo every 4 days, 90% of the time they had a factor rate level of more than 5%. Now, even those 38 patients that were then randomized to the 75 units per kilo, they showed a mean trough level. So that's a level right before the next dose, which and it's the level that occurs 7 days after you had just last received it, was 1.2%. Now that is very good, but I would say that is a selected group of patients. Not all patients will show a trough level of 1.2%. These are a little bit selected patients, but it does mean that some patients, especially if they're blood type AB, for example, could be on this product once a week and have very good protection. Now in children, we know that pharmacokinetics in children are not as good as they are in adults, so the pharmacokinetics improve as these children get older. So in the youngest children, their trough levels were 1.2%. And now this is after 4 days, because they had a 3-day gap and a 4-day gap. This is actually the 4-day gap. And in the 6 to 11-year-olds, their trough levels were 2%. Those are the lowest levels that they have. But notice that they're always above 1%. Now, shown on the next 2 slides are bleeds that occurred. Now, as I told you in the beginning, we don't want bleeds. The lower the bleeding rate, the better. Most of us in the world want to see bleeding rates of no more than 1. So I think, patients will tolerate 1 bleed per year, but we don't want more than that. And if it's lower, it's even better. So in the Pathfinder 2 trial, in adults and adolescents given 50 units per kilo every 4 days, in the main phase, those the first 43 weeks, the annualized bleeding rate was 1.2. But as these individuals continued on the product, the annualized bleeding rate fell to less than 1. It was 0.8 if you include the main and the extension phase. And that's important because it is less than 1. And on top of that, 40% of patients reported no bleeds in the main phase or the first 43 weeks of the study. Now, in children that were given the product twice a week, at a slightly higher dose, 60 units per kilo, during the main phase, they reported 1.9, an annualized bleeding rate of 1.9, which is a little bit higher than what I would want. But notice what happened when they continued on the product in the main and the extension phases. So as they continued on it, their bleeding rates actually fell to less than 1. And that's quite good. On top of that, there were some children, because this was an international study, involved parts of the world where maybe prophylaxis wasn't being done as it is in, let's say, my country or my center. So some children actually had target joints. There were a total of 16 target joints in all of those children put together. And within 12 months, as you can see on the x-axis, most of those target joints went away, meaning they were no longer bleeding. So they were no longer target joint. A target joint is defined as a joint that's bleeding repetitively many times in a short period of time. And by the 25 mark of being on this 25-month mark of being on the study, all target joints resolved. So if you put patients on prophylaxis twice a week, these are children, over time, their bleeding rates will drop and drop, and to the point they're no longer bleeding repetitively. So the product has also been used for surgery, so it could be used for surgery safely, as I'm going to show you, and that was part of the Pathfinder 3 trial, which was a surgery trial. There were quite a lot of surgeries. There were a total of 45 major surgeries that occurred in the Pathfinder 2 trial. Most of these were orthopedic surgeries. And in the Pathfinder 5 trial, there were 41 minor surgeries. And hemostasis was considered successful in virtually all of the major surgeries, where using this product, they were able to prevent any bleeds from occurring or any significant bleeding from occurring. A little bit about safety. And whenever a new product is developed, one of the most important things is if you give it to people, will they develop an inhibitor to it? Now, these are all previously treated patients. There is a PUP study that is ongoing. It hasn't yet been reported. I think it's actually complete, but it hasn't yet been reported. And so clearly, any factor VIII, if you give it to PUPs, patients who have not been treated before and now are receiving factor for the first time, you're going to see some inhibitors. But when you give it to previously treated patients, you don't want to see many inhibitors. You will tolerate 1 or 2 inhibitors, but that's about it. So what happened here is that in the adults and the adolescents, there were 186 patients. Most received the product prophylactically, 12 on demand. 1 patient did develop an inhibitor. In the children, no children developed an inhibitor. Again, these were previously treated patients. None developed an inhibitor. So overall, of the 254 patients that were placed on this product, 1 developed an inhibitor. This is actually expected. If you take 254 individuals with severe hemophilia and you just follow them for many, many years, inevitably, some of them, or 1 or 2, will develop an inhibitor at some point. So this is actually quite expected. So there's no safety concern when it comes to switching patients to this product and inhibitor development. Now, what about the PEG? So what I'm showing you here is anti-PEG antibodies. And the interesting thing here is that of the 186 adults and adolescents, 12 of them actually had pre-existing anti-PEG antibodies. And what that's telling you and me is that we're all exposed to PEG. So I might have PEG antibodies because I eat PEG. It's in different foods, it's in different well, I don't use cosmetics, but it's in different products, shampoo and conditioner and things like that. So a lot of us have anti-PEG antibodies, and these patients did as well. In most cases, the anti-PEG antibodies disappeared. Notice that the children actually showed even more anti-PEG antibodies. 20 of the 68 children, before they received this product, already showed anti-PEG antibodies. Most of those disappeared. A few patients developed anti-PEG antibodies during the course of the trial. The question is, was it because of getting a PEGylated product, or was it because of exposure that we all have on a regular basis to PEG? Most importantly, none of those antibodies, those anti-PEG antibodies, affected factor VIII activity or the clinical response to Nhgp. There were no other safety concerns that were found. And we can get into it. I don't have any slide here, and it's on PEG. Is PEG safe? I think a lot of you might be asking that. I think the most important thing is, and we'll get to it when I show you my experience with using this product, is that we now have, just on this product, 250 patients that were on it as part of studies. Now there's some other patients that are on this product outside of studies. There's other PEGylated hemophilia factor concentrates. If you put all of the PEGylated factor concentrates together, there are thousands of patients on these things. Some of them have been on these things for 8 years, and yet we're not seeing any toxicity. So I believe that as time goes on and we're not seeing toxicity with these products, and we have now thousands of patients on PEGylated products, I believe that these are safe products. Now, what about health-related quality of life, which is very important when it comes to hemophilia? We want our patients to be able to live a life that is not a miserable life. We want them to have a quality of life. And so what I'm showing you here is just the annual number of injections that these patients would receive and how that compares to really the past, I guess. So in adults, on this product, adults and adolescents, they were all over 12 years of age, they would receive this every 4 days. If you do the math, every 4 days means you get 91 needles per year. Now, that's still 91 more needles than I get. I don't get any needles per year, knock wood. That hopefully that'll continue. But these, on every 4 days, they get 91 needles. And the patients that were put on every 7 days, they would get 52 needles. The children, they were on twice a week. That means 104 needles. That's still a lot of needles for all of these things. But if you use a standard half-life product, we know that most patients will need a standard half-life product every 3 days, and they would need 156 needles in a year, or they would need to receive it every other day, which is about 182.5 needles per year. So this is still a significant reduction in the number of needles that these patients would receive by moving from a standard half-life to an extended half-life. Now, what about just measuring quality of life or health-related quality of life? And as some of you may know, there are different tools. So there's what's called the HemoQual, that's for children, and there's the HemAQual, the A for adults. And what I'm going to show you here is what happened to their HemoQual, HemAQual measurements when they went on this product. And so if their health-related quality of life improves, then for these HemoQual values will drop from baseline. So this line, the 0, is where they start. If their quality of life gets worse, the lines are going to go up. And if quality of life gets better, the lines are going to go down. And this is what happened. Quality of life improved, particularly for the youngest children, the 4 to 7 years old. They showed the best improvement in quality of life as measured by the HemoQual. But all of the groups showed improvement in quality of life, but especially the youngest ones. Now, this is satisfaction scores. And here, it's sort of different. What I'm showing you right now is their baseline values for these various things at the bottom: ease and convenience, efficacy, etc. And a high score is bad when it comes to this, and a low score is good. So this is at baseline. And then at the end of the main phase of the study, what was their, how do they report their satisfaction? And if things go down, that's a good thing. And if things go up, that's a bad thing. And as you can see, there's improvement. At the end of the main phase, for all of these various things, patients are reporting better values. So their treatment satisfaction is improving by moving to an extended half-life product like Esperant. So overall, the Esperant clinical program showed a lot of benefits in this Pathfinder program. So first of all, the annual bleeding rates in adults and adolescents and in children during the extension phases were less than 1. That is very important. So these patients with this product are not going to bleed very much. They're not going to get the joint damage that Fawaz showed you earlier. Second, at a dose of 50 units per kilo every 4 days, which is a very simple regimen, adults and adolescents have a mean factor VIII trough level of about 3%. And that contributes to why their annual bleeding rate is quite low. 96% of major surgeries were successfully managed with this product, and both children and adults report improvements in health-related quality of life. You might also be asking, can you measure Nhgp with your usual assays? And so what Novo Nordisk did is they did an Nhgp field study. They took samples and so plasma with Nhgp in it, and they sent it to 67 laboratories in 25 countries throughout the world and asked those laboratories to test the Nhgp levels to see how accurate those laboratories would be. And what was found is that Nhgp can be accurately measured using all chromogenic assays. So the chromogenic assays in all of these laboratories where they were used, they got it right. They got the correct Nhgp value. And most one-stage assays were fine and could measure Nhgp. There were only 3 silica-based one-stage assays that underestimated Nhgp, but no assay overestimated Nhgp. And that's important. You don't want your laboratory to say, oh, the patient has a 30% factor VIII level when in fact it's only 2%, and maybe the patient needs another dose of factor. And your lab would have goofed that up, but that didn't occur in any case. And now, lastly, in the last few minutes, I just want to talk about my personal experience using Esperant. So in Canada, we don't have Esperant available as yet. We may have it. We have a tender system. In your country, there's also a tender system. So you may have it. We may have, but I have been using it for quite a long time. So in 2013, I participated in the Pathfinder 5 study. This was for the children. And we enrolled 2 patients. We actually wanted to enroll more, but by the time it went through our REB and we got everything rolling, they had almost completed their enrollment. And so we only put 2 patients in. One was a 7-year-old and the other one was an 11-year-old. Here's the 7-year-old. So the 7-year-old, before he went on to Esperant, he was on Advait and he was receiving Advait twice per week. But in the year before he went on to Esperant, he actually had 3 bleeds. And I don't want them to have 3 bleeds. So I was going to escalate him to 3 times a week. And I was going to have that conversation with his parents. But I said, well, that's one option. The other option is you can switch to an extended half-life product like Nhgp as part of the study and stay on twice a week. And so that's what he did. He went on to the Pathfinder study. He stayed on twice a week. He was getting it on Sundays and Wednesdays. Sunday is a convenient day. His family didn't work on Sundays. He's at home, not going to school. And so that was a convenient day. So there was only one day during the week, during the work week, where he was getting factor. And he has remained on twice a week throughout the entire Pathfinder 5 study, which went on for 5 to 6 years. And then he continued on the Pathfinder 8 study, which was a continuation of the Pathfinder 5. And that finished last year, but he wanted to stay on the product. And so Novo Nordisk kindly has been giving it under compassion to us to give to this patient. So he has remained always on twice a week, and he's been on the product now for about 8 years, and he is now 15 years old and doing well. He is A blood type, so he tends to have a higher trough level than most children, and his trough level measured at around 3.5 days is around 2.8%. The other patient, at the time he was 11 when he started on the product, he is now 19 years old and he is now in university. When he, before he went on to this product, he was on twice a week Advait. And surprisingly, because he's AB blood type, his half-life on Advait was terrible. It was only 9.25 hours. We only did it once. Maybe if we had repeated and got some other values, maybe it was a little bit higher because that was really bad. His estimated factor rate at 48 hours when he was getting Advait was about 2.5%, and he was only getting it twice a week. And I was going to escalate him also to 3 times a week because he had had 3 bleeds in the previous year, but sat down with him and his family and talked about Esperant, and he wanted to go on it. And so he went on it, and he was receiving it twice a week. He would normally get it on Monday mornings and Thursday mornings. He was on it for many years. And then at one point, he wanted to do these sports, American football and rugby. And these sports, there is a lot of contact here. And I was very worried about him doing these. And I said, it's fine. If you really want to do this, I want your quality of life to be good. But you need to go on Esroc 3 times a week. And so that's what he did. He went on it 3 times a week. He would get it on Mondays, Wednesdays, and Fridays, generally in the morning. Sometimes Wednesdays it was after school. And that would allow him to then play sports and practice. And he did that for several years. And then when he was going to university, and then with COVID, of course, hitting all of us, he said, I don't need it 3 times a week. Let me go back to twice a week. And he did. And he's been getting it on Sundays and Wednesdays. His factor rate level after about 3.5 days after getting the product is around 3%. He's done these things, and he did them without any bleeds, although he fractured his finger once, but he didn't really have any bleed there. He just fractured it. So these 2 patients have been on Esroc for 8 years. They've done very well. Their annual bleeding rate over the 8 years has been about 1. They've had no severe bleeds. They've had no adverse events. They obviously did not develop any inhibitor, and they've wanted to stay on it because up until now, there hasn't been any other product that really is any better than Esperant, and they may be certainly worse than Esperant. my final take-home points are shown here. And I put the fact that Esperant is stable at up to 40 degrees Celsius. Because in your country, I think that might be important as you're transporting. Hopefully the air conditioning in the cars doesn't go bad, and the temperature would go up a lot. So you usually don't have to have Esroc at 40 degrees, but if you did for even a short time, it'd be fine. Twice a week dosing in children or every 4 days in adults is good for most patients and ultimately results in an annualized bleeding rate of less than 1 on average. There's always a few exceptions. Esperant showed no safety or inhibitor concerns when patients switched to it, and Esperant has been used now by patients for over 8 years continuously, and it certainly offers another extended half-life factor 8 that you can confidently use. And I think, personally, all my patients, or virtually all my patients, 95% of my patients are on extended half-life products. And I wouldn't put anybody on a standard half-life product personally. Of course, there's emicizumab, and that is of value to many, especially younger children. And we could talk about that as well. And with that, I thank you for your attention, both in English and in, I think, in Arabic, I'm hoping. And I will be glad to take any questions. So thank you very much.
Thank you, Professor Karkau, for your usual and excellent presentations. I used to listen from you many interesting presentation about hemophilia and the bleeding disorder since I was a fellow in Canada. And I still remember how value your talk and the way you present your lecture or presentation. We'll take questions. We'll look at.
So you'll read the questions to me, right? Because
Okay,
some of them are in Arabic, and
some
I can't read
Arabic.
them.
I cannot read Arabic anymore.
Oh, okay. Well, don't look at
No,
me.
no. Let me see. What is the questions? Okay. Questions and answers. Yes. Muhammad Abu, what is about acquired hemophilia?
Yeah, you know, I don't think that today's talk is on acquired hemophilia. That's a completely different thing. Acquired hemophilia is not seen in children. It's seen in adults. It's treated differently. It's more immunosuppressive therapy. You know, it's not, you know, could this product have a role? Yes, not really. I mean, it's really more immunosuppressive therapy and getting rid of the inhibitor, using bypassing agents, maybe emicizumab. It's a completely different area.
Yeah, the other questions I got here, would you, without PK studies, adjust your treatment frequency based on the blood group and the von Willebrand factor level?
Yeah, you know, that's a very interesting question. I do think that you could, you definitely could, because if you switch a patient from a different product, let's say it's a standard half-life product to Espera, an extended half-life product. If there were O blood type, I would say to the family, you know, at least twice a week, maybe every 3 days is what you need. If it was an AB blood type individual, I would say, look, you could probably go every 4 days and, you know, try it, maybe every 5 days because of the blood group. And then you can see how the patient does. Now, personally, I like to do some. Now, you know, when I say PK study, it doesn't mean you've got to do many points. All you need is you need a few points. You need to know exactly what time the blood was taken in relation to the previous dose. So if it's 96 hours or 72 hours or 68 hours, you need that. And then using WAPs or different programs, I can just do it in on pencil because I've done so many of these. I can figure out the half-life of these patients, but you do need some samples in order to then maybe do some adjustments. So yes, I do take blood group and VWF levels into consideration, and I always do VWF levels on all patients that I diagnosed with hemophilia. Even hemophilia B, I still do it. The next question is on hemophilia B products. Is there similar products for hemophilia B? That's a completely another talk, but extended half-life products now exist for hemophilia A and exist for hemophilia B. And for hemophilia B, there are 3 extended half-life products, but 2 of them, including one that's made by Novo Nordisk, have much better pharmacokinetics than the other. And so in hemophilia B, the use of extended half-life products is really important, and it's really transformed the lives of patients with hemophilia B. So absolutely. And here in my institution, I don't have any patient on prophylaxis with standard half-life factor 9, none. All patients on prophylaxis are on extended half-life factor 9.
Excellent. I think if there is any more questions, yeah.
I mean,
what is the cost? About the cost, I mean, what is the cost difference between Esperant and the other extended half-life factor 8 product?
So I can't answer that. Of course, it depends on the country and it depends on what the companies decide to do. I personally, I think these days, the price of the extended half-life products are actually now becoming very comparable. So for me, if they're comparable, then I just want to choose the best product. And it's getting to a point that the extended half-life products, maybe, some patients could be on one, some patients could be on another. I think that that's fine as well. They're all quite similar. It's not to say that, one is so much better than the other. I think that they're quite similar. And now throughout the world, the prices are getting to be similar. Now, are they more expensive than standard half-life? Yeah, probably. In most places, they're more expensive. Does that impact on me? Not really. They're not so much more expensive. The prices of extended half-life in Canada has come down a tremendous amount. They're a little bit more expensive than standard half-life. Are they worth it? Yes, absolutely. As I told you before, I don't get any needles per year. Now, knock wood, hopefully I won't get sick tomorrow or something, but I don't get any needles. If you said to me, you can either get 91 needles or you can get, 182 needles, what do you think I'm going to pick? I don't want any needles, but I would certainly prefer 91 over 182. So I think it's very important that we think of our patients, especially children. None of them like a lot of needles. So yes, I would always pick an extended half-life over a standard half-life.
I have a question. What about if we, for the extended half-life, if we move from one company to other product, is that will increase the tendency for the inhibitors development, or that will not have an effect?
No, as you can see with my head moving back and forth, no. In Canada now, we've, because of tender, we used to have, in my center, we had most of our patients on eloctate. And then eloctate disappeared because of the tender, and we had to move most of them to Adinavate. There was no inhibitor development. And we may be moving them from Adinavate to Espera in the next year, who knows? And I'm fine with that. I don't believe that these products and moving, and it's what we did in the past when we had other standard half-life products, they don't seem to result in inhibitor development. So I think it's fine to move from one to another.
Okay. Is there any other questions? If there is no other questions, we'll thank the audience. We'll thank Professor Karkao. We'll thank Dr. Fawaz Al-Qasim for their excellent presentations, and we'll thank Novo Nordisk for inviting all the speakers, including me, for this valuable meeting. Thank you very much.
Thank you.
Bye. Thank you.